thanks for the opportunity to speak. I'm going to talk about 3 different ways to do a discectomy through microscope, loupes, and tubes. And I don't have any financial disclosures. My only disclosure is I use or have used all these methods, and I love all of them. I think that they all have a place in practice, so I'm really excited I get to talk about this. My practice is about 90% time at an academic medical center with residents and like 10% in the middle of nowhere by myself in West Virginia. So a lot of different ways that you can use these things. First, I want to ask what you all use. Who learned to use or uses just the microscope for microdisc? Okay, who uses just loupes? All right, who uses like some combination of microscope and loupes? And then who uses tubes? Okay, awesome. Of the people that use just the loupes, who are ortho and who's neuro? Okay, awesome. All right, so what does the data show about these different techniques? That's kind of boring. There's a lot of clinical studies and meta-analyses about these things, but like all microdiscs are kind of MIS, so there's not a ton of difference. There's some short-term benefits of the less invasive methods like a tubular discectomy, but the differences are pretty small, and all the procedures are overall pretty successful and show comparable long-term pain relief. So we don't have to talk too much about outcomes. I'm going to talk mainly about what situations are best for what methods and how you might go about teaching yourself a new method if you've find that the one you're currently using or that you were taught when you were in training doesn't work anymore for your current setting. And I'm going to focus a lot about that practice setting piece because it's especially relevant for you guys who are going to be going out into practice on your own before too long. So when I looked for information about who uses these different techniques, this is the one recent paper I could find, which surveyed Canadian spine surgeons in 2007 and again in 2017. And they found at both time points that the majority of surgeons were using just the microscope for visualization, and the proportions of surgeons using loupes alone dropped by about half over that time. So in 2017, only 10% of surgeons were doing that. And then the people that were using tubes increased about threefold. So with that in mind, I'm going to talk about the microscope first. So obviously the microscope has a fantastic visualization, not only for you as a surgeon, but for your assistant and like everyone else in the room if you have a monitor. But that comes at a very real monetary cost, which isn't a big deal if you're going into a practice that already has invested in one of these. But the cost can be a lot, and it can be a big ask if you're going to some place that doesn't already have a microscope. And the hospital, of course, also has to consider upfront costs, but also maintenance costs and who's going to be doing that maintenance and like where they're going to put it. And for all that trouble, your microscope isn't really portable. So if you're operating at multiple sites, you might not have a scope at all of them. And then aside from that cost, there's obviously like a small learning curve in knowing how to use it. I found some like really old data like from the 90s when microscopes were newer, I guess, that suggested maybe an increased risk of infection when using the scope for spine surgery. But obviously the microscope is unparalleled in terms of visualization, which can be great when things are complicated, like when you have you're repairing a CSF leak or for learning scenarios where you want to see what your trainee is doing, or you might want to have, your trainee might want to see what you're doing. But exactly how much money are we talking about here? So the scope that I just showed you in that pic, which is admittedly kind of top of the line, is $900,000. So that's not a small expense. So if that seems a little rich for your blood and you can't get that out in practice, you can just use loupes for a microdisc. The benefits of using loupes is that they are cheap. You most likely already have a pair, and they're portable, so you can take them to like any hospital that you might operate at in the entire world. The main downside is they offer less optimal visualization due to less magnification and inferior lighting, but you can obviously get a headlamp. And so when using loupes, I think there are 2 things that are important. One, you want to be cognizant of your ability to address complications like fixing a CSF leak with just the loupes. And you also want to consider that your style of operating is suitable for the less magnification that you'll have. And then you also want to make sure that you have a retractor that gives you enough lateral retraction and medial visualization. And I think the reason this matters is that when you're using loupes, your focal distance is higher and it's far away from the patient and more off to the side than a microscope. And so that lateral skin edge can obstruct your view, but certain retractors can help with that, which I'll talk about in a minute. The other thing you want to consider is that your technique of operating is amenable to this. So when I was a resident, I learned how to do a discectomy. It was kind of like we were doing aneurysm surgery. Like we would like skeletonize the veins very carefully, and then we would like bipolar them, and then they like cut them with the micro scissors. That doesn't really work with loupes, in my opinion. All you have to do is push those veins out of the way and like put some hemostatic agent and a patty, and just keep going. And so if you're using all those kinds of things, you might struggle a little bit. But loupes with those considerations are really great, especially for operating at multiple places or when you don't need your learner or your assistant to see very well. And so in order to get that appropriate medial visualization, you need good lateral retraction. And so this is one good way to do it. This is a talar retractor, which has a little hook on the end. And so after you finish your subperiosteal dissection, you insert the retractor, hook it behind the facet, which locks it into place. And then you can secure the other end either with like rubber bands and a hemostat, like in this picture, or my fellowship director taught me to use acrylics, so we called it a bug ladder. You just like drop it on the floor and step on it and then tie it, and that works great, except for if you have to change the bed height. And so that doesn't waste any of the retraction on that medial side of that incision, because like you don't need to see medial, that's useless, and you're using all your skin elasticity on the lateral side to help you see. And so this paper was published actually kind of recently by a neurosurgery group in India at World Neurosurgery, but I mean this technique has been around for years. And then lastly, tubes are a great way to visualize for a microlumbar disc. Now one caveat here is I think you really need to be able to use a microscope or an endoscope also to look down the tube, so consider that before trying to start using them. It's not like an either or. And again, I'm not going to go into the use of the endoscope because someone else is going to talk about it, but these tubes have kind of a moderate learning curve, so you need to have a good practical knowledge of anatomy since you'll be seeing a lot less of it, and the angles might be different, which is particularly relevant. I'll talk about that in a second. You're also operating in a smaller rigid space, so you have to maneuver those instruments differently. But the benefits of using this system is one that it also often comes with like a complete set of instruments, and if you're using the microscope, those are going to be bayoneted, and they're sometimes really slick. Like there's a suction that has a foot that also kind of serves as the nerve root retractor. So if you're operating completely by yourself, like that's a great way to do it. You really can't get a second person in there, and if you're trying to operate on your own without that kind of instrument, it's actually kind of hard to like do the suction and do the operation and retract the nerve root at the same time, or if you don't really trust the scrub tech or whatever to be an assistant. So that can be really helpful. And again, that's especially useful when you're operating at like multiple hospitals, but you want to have like a standard set of instruments, which is easier said than done in many places. Or if you want to have really nice instruments, like say the orthopedic surgeon's been drilling on your metal suction tips and they got these like spiky edges on them, like these come with a suction tip, so everything can be really nice and only you get to use it. And so there are some, better short-term outcomes related to decreased infection and that kind of thing. But long-term, those don't have like a huge impact on the ultimate outcomes. And so, if you're worried about specific complications, this is a good thing to sort of consider. Or in certain high-risk populations, like high BMI patients, a tube can be really a reliable retraction method. So those are some situations where you might want to use it. And so this is one of the benefits of a tube are less traumatic muscle dissection with good sort of rigid deep retraction. And you can see here on this diagram that the angle of view at the end of the tube is actually pretty good. It's better if your tube is shorter versus longer, and it's obviously better if your tube has a bigger diameter. And I assume most people have probably used some tubes, but if you haven't used it before, this is what it looks like doing the dilators on a lateral x-ray. You can see all the different tubes or the dilators stacked here with the actual retractor, which is really short down next to the skin. You anchor it usually to the contralateral side to the table, and then the retractor itself is a little bit more radiolucent. And when you're looking down into the tube, this is kind of what you see. It's like kind of a bunch of red mush. You want to make sure that any muscle that you still have there needs to get out of the way, and you have to make sure you really define your bony anatomy. And I think that can be tricky with this because you don't have that like tactile feedback that you get in doing an open dissection. You just sort of have to figure it out when you see it, so you have to be careful of that. The other thing you have to be careful of is that your angle in relation to the spine is appropriate before you start your bony work. And this just kind of demonstrates two different angles that you can get. This is the angle you want for a discectomy. It's pretty vertical, although the incision is still off the midline. And you can see here that it's like pointing you right at that sort of like posterolateral part of the annulus where the disc is going to be. If you have it more angled like this, like you would do for a contralateral decompression, you're going to take this bone, you're going to take some of the ligament and flavum, and then boom, you're going to be in the contralateral side, and you might not even realize it. And so that's important to notice that. And this is just a technique for making sure that you get that correct angle. So facet hypertrophy is something that can sort of direct you more medially than you want. And so this sort of shows what that facet hypertrophy does. And then even if you just drill a little bit of that medial facet, you can stand it up better and get the angle that you want. And this is just showing how easy it is to kind of get to that contralateral side. So this is with an angle like this. You come over here, you do the bone work, take off your ligamentum flavum, and then you're already at the contralateral nerve without necessarily realizing it. And so that's important. You definitely need to understand where your angle is in relation to that. You can also use angling the retractor a little bit to your benefit. That you can do what's called wanding it, which is like releasing the bed anchor and just sort of move it around a little bit, and you can change your field of view that way. So in the end, which way should you use? I hope that you kind of understand that all these things are really good, and it really just depends on what's best for you and what's best for your environment that you're practicing in. And so I like to sort of teach my residents all these different things. And so when I'm teaching, say, for instance, one of my neurosurgery residents to use just the Loupes, I'll make them go further along in the surgery without the microscope a little bit each time. The microscope is draped and it's sitting there, and we just bring it in whenever we're ready. And eventually they don't have to bring it in at all. Okay, when I'm teaching the orthopedic fellow to use the microscope, we bring the microscope in right at the beginning and start with the incision because the microscope has the least amount of depth and the least amount of mag right at the beginning. And as you're sort of slowly progressing along in the operation, you're just incrementally increasing those things. And so it's a really natural way to get down at that increased depth without really even noticing it. And then for tubes, I think the best way, it's kind of a single person operation. So I think if you're trying to roll that into your repertoire as a surgeon out in practice, I think it's really important to do a certain number of microdiscs open before you try to do this, because it's kind of easy to get lost, and you want to make sure that you don't do that. And you don't want to have any of those sort of like typical challenges of first time, doing a surgery on your own with this. So with that said, thank you, and I'll take any questions.